Abra, do you have any updates to kick us off?
Yeah, well, just welcome everyone. As Camille said, this is our first Housing is Working Group event of the year. Fun fact, for those of you who have not been with us since the beginning, part of the reason we're on an academic schedule is because this started as the Education Working Group. Um, so thank you for joining us. We're glad to have you here. The only other thing I wanted to add is that keep an eye out because very soon we will be sending out an official save the date for the 2024 summit, which I think most of you know, or all of you know, is our annual cross-sector conference. So that will be taking place in May again. And the other thing to keep an eye out for is the proposal submission application. So lots of you on this meeting today have presented at the summit in the past, but we, for the last several years, have done a solicitation process for the breakout sessions. We typically have kind of three main tracks: education, health, and partnerships. Recognizing, of course, that many of your sessions could fit into many of those buckets. So if you have exciting initiatives that you all have been implementing or evaluating, data or research projects, policy efforts, and you think that it might be great to present it at the summit, please keep an eye out for that. We'd love to hear from you all.
Great. Well, with that, I will turn it over to our presenters for today. We are so pleased to welcome researchers from the Johns Hopkins University. We have Dr. Craig Evan Pollock, Dr. Lakin Roberts Levine, and Dr. Tori Grant, who are going to be presenting on the Asthma Mobility Project. And I will turn it over to them to do any more introductions and to take it away.
Great. We just want to start by saying thank you so much. We really appreciate the chance to talk with you all. And this is a nice and small group, so please feel free to come off mute, ask questions as we're going along. We have a lot of slides to go through, but also we don't need to get through all of them. We can stop and kind of have discussion at any and every point along the way. So I'm going to go ahead and share my screen, and then I think, Tori, you're going to start and talk a little bit about the setup for this project. Also, I'll put in the link for the paper that we're going to be talking about that was published in JAMA. I understand that it's hard because it's behind a paywall. If people have trouble getting access to it, please send us emails. I'll put my email in the chat as well.
Hello, everyone. I'm Tori Grant. It's very nice to be here with you. So I'm just going to talk a little bit about childhood asthma and how it's a public health priority, and a little bit about the intersection of childhood asthma and living in urban neighborhoods. So asthma, first of all, is the most common chronic childhood illness, and it accounts for a large burden to the healthcare system through emergency room visits and hospitalizations. Children with asthma who live in urban neighborhoods experience a disproportionately high asthma burden, with increased incident asthma, increased asthma symptoms, exacerbations, and acute visits for hospitalizations for asthma. And it's thought from an allergist standpoint, there are multiple urban exposures that contribute to this increased asthma risk and asthma morbidity, such as pest allergens, mold exposure, endotoxin exposure, and indoor and outdoor air pollution. Specifically, children with asthma have a much higher prevalence of asthma compared to children who are not living in urban centers. And it's thought to be anywhere from 2 to 3 times more common. And with children who are Black children living in urban centers, as well as Afro-Caribbean children living in urban centers, have an even higher prevalence of asthma compared to their counterparts. And most importantly, or not most importantly, very importantly, children with asthma, it's a big cause of school absenteeism, and is a large strain not just on the child's health, but also on the family. Okay. So again, we think in allergy that indoor exposures and outdoor exposures are a big driver of childhood asthma morbidity, particularly children living in urban areas. Pest allergen exposure, such as mouse exposure and cockroach exposure, has been extensively linked with asthma symptoms and risk for hospitalization and emergency room visits for asthma. Additionally, children living in urban centers also experience a disproportionate risk for pest exposure because poor housing quality and substandard housing is a risk for pest infestation, and mouse infestation is a risk for cockroach infestation. So it's unfortunately a spiral. And you can see just here from these pictures that home disrepair creates a conduit for pest infestation, with mice and cockroaches being very common exposures, particularly for children in Baltimore. Mouse allergen has been repeatedly shown to be a major contributor of both asthma symptoms as well as asthma healthcare visits and hospitalizations. It's very difficult to eradicate mouse infestation in Baltimore City as well as other cities, and it's also difficult to eradicate cockroach infestation, largely due to often the just sheer disrepair of housing for these families. And unfortunately, environmental control studies and studies that have tried to mitigate exposure and lower mice and cockroach in homes have really yielded mixed results, with some results showing that they were able to consistently lower allergen exposure levels and therefore affect asthma symptoms or asthma severity, with multiple other studies showing that this going in and trying to eradicate the pests in the home is not successful, and then unfortunately they don't have any change in their asthma symptoms or any change in asthma medication or exacerbations and hospitalizations.
And I just want to add that I think this is often where we kind of live in the world of housing, where you're like, okay, we're going to go in and we're going to clean up a unit, we're going to remediate that unit to try to reduce exposures, and that's going to help kids with asthma. And under, as Tori was saying, kind of under ideal scenarios where study teams are going in, it's distressing kind of that not that these don't work at all, but that getting a sustained reduction in these is really, really, really challenging, especially in a place like Baltimore, where we're in row homes where units are often kind of connected to one another. That this can be a major driver, and the solution is unfortunately not as robust as we would want it to be.
Also in Baltimore, there's large areas of abandoned homes, which can create even a bigger problem for trying to eradicate the pest infestation in homes that are occupied. So this is a map from 1937, which shows the historic redlining which took place in Baltimore City, and you can see that it was concentrated in the downtown urban area. And as you got farther away from the urban center, those homes were considered less risky. The redlining coming from the actual red color, where Black families were historically profiled, and historic and systemic racism led to those families having a harder time securing a mortgage. And as you got further out from the city center, those areas were considered less risky. And you can overlay this map with the current Baltimore City map, where we can see, well, this is a map of asthma hospitalizations by zip code, and you can see that the colors are very, very similar to the redlining map. And there's a very similar green space map for Baltimore City that looks exactly like this, that as you get further out from the city center and further out from where the historic redlining was, there's more and more green space. So concentrated in the city center, where historic redlining occurred and racist mortgage lending practices, there are higher rates of poverty, higher rates of asthma, and hospitalization for asthma, and lower green space. Then you get further out and those hospitalization rates and green space improves. And so not only are children at higher risk for urban exposures, such as the pest infestation and mold exposure, they're also unfortunately at risk for socially disadvantageous social determinants of health, such as increased poverty, higher rates of obesity, and higher rates of chronic stress. Chronic stress has been implicated in asthma exacerbations, both from a perceived parental caregiver as well as a patient or child standpoint. And we know that caregiver stress has been associated with asthma symptoms, and parental stress has also been linked with inflammation in children. And stress during pregnancy predisposes children to developing a biological phenotype that puts them at risk for allergic disorders, a main one being asthma.
So with all this as a background, with the idea that asthma presents a tremendous burden of disease, there's tremendous inequities in asthma, and that we know that the history of systemic racism in our housing policies have contributed, we think, to the unequal asthma burden. And the idea also that there's a lot of exposures that play a role, including the potential role of stress. We wanted to try to understand what's the impact of housing mobility, both as an analytic lens, helping us understand what are the aspects of neighborhood environments that change, and also as a policy lens, kind of a lever that can be pulled by people in CLAFA and HUD and others to try to address asthma as a health disparity. And the first way we investigated this as a team was by looking at the Moving to Opportunity experiment. And so many of you have, I'm sure, are very familiar with Moving to Opportunity on this call, which was this amazing randomized controlled trial that was started in the 90s by HUD, where they randomized families living in public housing located in high poverty neighborhoods into different control groups. There was people that received a traditional voucher, then it was a Section 8 voucher. People received a voucher that helped them move to lower poverty neighborhoods, and then a control group. And so that was really important from a scientific perspective to be able to disaggregate and understand what was going on. Although a lot of advocates kind of felt that Moving to Opportunity didn't work very well, that a lot of people didn't actually move with their vouchers, didn't stay living in a low poverty neighborhood. And at the kind of the long-term follow-up of Moving to Opportunity, they looked at asthma and they asked about asthma, and there weren't any self-reported differences in asthma symptoms over the preceding 12 months. So asking people to remember what happened in the preceding 12 months, as you might imagine, is hard. I often don't remember what I had for breakfast on any given morning. And so that was done by the evaluators of the long-term follow-up. We, working together with others, tried to look at what happened to actual healthcare utilization. And to get at that, we merged data on Moving to Opportunity with these kind of like little breadcrumbs of like what happens when people use the healthcare system, their insurance claims data, the all-payer data. And we found that there was a significant reduction in hospitalizations among children that had the chance to move, that they got a voucher. There was significant reduction in hospital spending for those children. And really importantly, there was a 36% relative reduction in asthma-related hospitalizations over a 21 year follow-up. So significant, we think, clinically meaningful, which kind of set the stage for the study that we're going to talk about now, which is the Mobility Asthma Project. And for that, we partnered with the Baltimore Regional Housing Partnership, or BRHP. And the Baltimore Regional Housing Partnership is a really absolutely phenomenal organization that started as a result of a class action lawsuit. So the ACLU of Maryland sued the U.S. Department of Housing and Urban Development, and claiming that they were violating fair housing laws. And as part of the remedy for that lawsuit, they've helped about over 5,000 families with a housing choice voucher move from high poverty to lower poverty opportunity neighborhoods. They use really extensive pre and post move counseling to overcome barriers that often constrain people to particular neighborhoods. And you can see here in 2018, which is a little bit older data, the pre-move poverty really went down from 37% to 8% in the surrounding neighborhood. So quite a successful program in their ability to help. And so this is the group that we partnered with. And Lakin's going to take over and talk a little bit about our study.
Hi. So the Mobility Asthma Project was a prospective cohort study of low-income Baltimore City children enrolled in the Baltimore Regional Housing Partnership's mobility program to determine the effect of moving from a high poverty to a low poverty neighborhood on asthma-related outcomes. And so MAP partnered with BRHP and in 2016 recruited children with asthma at the Family's Initial Housing Counseling Workshop. And so families were followed up to 1 year after moving into their new home, although due to COVID-19, we only report on data that we collected prior to the start of the pandemic. And so to be eligible for MAP, children had to be between the ages of 5 and 17 and reported either having persistent asthma or having experienced an exacerbation in the past year. And we exclude children that had other health conditions like lung diseases or that they were confirmed smokers. Next slide. And then as families move from Baltimore to opportunity neighborhoods, we see that they typically move from high rises or row houses, such as the ones pictured, to low rise apartments or houses. Of note, these are not actual pictures of the actual homes of MAP participants. These were pulled from the internet and real estate listings, but it just helps provide a visual of the differences in the homes and neighborhood environments that the families live in as they move from Baltimore to the surrounding county areas. And so participants were enrolled at a baseline home visit and had repeated home visits every 6 months with phone calls every 3 months in between. The MAP team had an extensive data collection process that captured information across a wide variety of topics, including quarterly assessment of asthma outcomes, home environmental exposures, including dust and air particulate matter, lung function testing, and stress measures, including neighborhood characteristics, caregiver depression, and discrimination. Next slide. And so looking at the children enrolled in the MAP study, we had 123 children in our final sample. Just under half were female. They were on average about 9 years old, and they were predominantly reported by their caregivers as Black. At baseline, slightly over half the children were sensitized to at least one allergen. About a quarter of children had experienced at least one asthma exacerbation in the past 3 months, and on average had approximately 7 asthma symptom days in the past 2 weeks. Next slide. And then the MAP caregivers were primarily female and self-reported as Black, and were an average age of 32.6 years old. Almost 2/3 reported working at a paying job, and although about 28% did not report household income, over a third did report that their annual household income was less than $15,000. And at baseline, a little over half of caregivers reported currently receiving rental assistance. And that number just slightly is asterisk because some people had already moved at the baseline, and so our denominator is just slightly lower for that statistic. Next slide. So this map shows the census tracts where MAP families lived prior to their move. This enlargement focusing on Baltimore, you can see that many of the red hatched tracts, which denote the family's pre-move census tract, these are colored darker shades of blue, indicating higher percentages of families in poverty in those census tracts. In the MAP sample, about 80% of families lived in a high poverty census tract prior to moving with their voucher. Next slide. And then in the second map, this shows the census tracts where families moved with their voucher during the study. And so here you can see families moved to several areas in the counties surrounding Baltimore City. And the census tracts they moved to tended to be lighter blue, so reflecting the lower percentages of families in poverty in those areas. In MAP, only one family moved to a high poverty tract with their voucher.
Great, so I'm going to take over and share the main findings from the study, which is that you can see here in the darker blue, you have the pre-move rates of exacerbations in the preceding 3 months. And on the right, you have the post-move rates of exacerbation. This equates to about a 54% reduced odds of having an exacerbation associated with moving. And this effect is really large, I think, for the kind of the non-clinicians in the audience, which is most of the audience here and most of the people we talk to, that, like, just to give you a sense that this is kind of on the order of the inhaled corticosteroids that we prescribe for my daughter who has asthma, kind of on the order of some biologic agents. So this is a really significant effect size, a significant reduction associated with people moving as a result of the Baltimore Regional Housing Partnership. This is showing the data in a slightly different way here. Each dot is like the pre-move rate of exacerbation, post-move rate of exacerbation in the post-move column. And you can see that a vast majority of the participants who just kind of get a general gestalt that the rate is really going down for so many of these participants. When we look at maximum symptom days, which is kind of how often did you report symptoms in the preceding 2 weeks, and it's kind of a combination of a couple of these different symptoms, you can see here that it went from about 5 days on average to about 2.5 days on average. So a 59% lower odds of symptom days associated with moving. Again, this is a really significant change associated with moving. And one of the things with asthma is that asthma often gets better as people get older. They become less symptomatic, and there can also be kind of other changes that happen over time. And so this isn't a randomized trial, right? We're only looking at people that are in the program, but we still wanted to have a comparison group. And so to try to get at that, we compared our sample, the MAP cohort, with something called the Eureka comparison group, which is a cohort of kids that were kind of recruited at birth from 4 different cities from high poverty neighborhoods, one of them being Baltimore. And we try to do different statistical things to try to get a comparable sample, trying to choose time periods when the Eureka people would have been eligible for our study, and then kind of following them over time, giving them a fake move date. Happy to go into the details of that, although I'm not sure. happy to talk more about it. We spent a lot of time trying to make this as comparable as possible. And what we found was that while there was a reduction in these exacerbations for the MOVE cohort in the blue, you see in the Eureka cohort that there wasn't the same change, that it's not just due to the cohort getting older. And this is on the right side, it's for the maximum symptom days. So again, we don't think it's just that people with asthma tend to get better over time. We think there's really something going on with moving that's important to unpack. And so as Lakin mentioned, as we were thinking about what's happening with moving, this study was also designed to try to get at what is it about moving that's causing some of these changes that might be mediating or kind of on the pathway between moving and your change in exacerbation and change in symptoms. And as Tori mentioned, we went in thinking that this was going to be about mouse and cockroach allergens. And what we found was that this is kind of measuring these different allergen levels that we measured in the vacuum dust samples from the children's bedrooms and other places. We found that there was a significant reduction in mouse and cockroach allergens associated with moving. So the levels got a lot better. In contrast, cat allergens tended to go up, dog allergens went up, and dust mites went way up in ways that some of the allergists on our team, including Tori, may have thoughts about and could talk about later. But this was not a major driver in our sample. And I think there's a lot of different explanations for that. Some of it might be that some of the allergens, while going down, others might be, others going up might have kind of mitigated the overall effect. Also, not a huge number of our kids were allergic to mouse or cockroach allergens, which are the big drivers. So it's not that these don't matter, but they didn't really seem to be the major drivers in our particular study. We also looked at air pollution in the house. We did these air filters that we deployed in the kids' homes, measuring particulate matter 2.5 microns and PM10, which are slightly larger air particles. We also looked at whether families reported cigarette smoking in the home, and did some objective measures of cigarette smoking. These also tended to become lower, get better as families move to opportunity neighborhoods, but change in cigarette smoking relatively small. And again, these weren't key mediators of the effect of moving related to asthma outcomes as we had maybe anticipated. So those were less important, and I'm now going to talk about the things that we think were more important in our sample, or more statistically related to the outcome. And here I'm going to talk about change in stress. So we measured stress according to a number of different dimensions, including neighborhood factors, parent-caregiver related factors, and child stress. And here we saw that really the reports of stress went down quite a bit. So people reported that their levels of social cohesion in their neighborhood was higher. Their feelings of daytime safety, feeling safe to walk around their neighborhood during the daytime, feeling safe to walk around their neighborhood at nighttime, really went up quite a bit. Caregiver depression decreased a little bit. Sense of urban stress decreased. And here I think this is really important, because this is a lot of the questions we get asked around discrimination, by moving to a new neighborhood, aren't people experiencing higher levels of discrimination? And in fact, we found the opposite. They were reporting lower levels of discrimination. When we look at these kind of mediation results, what's the relationship between between moving and asthma, kind of how much do these factors matter? We found that they matter quite a bit. Especially when you look at neighborhood factors, we found that that these different neighborhood factors, all of which are related to each other. So it's not like you can look at neighborhood social cohesion without also thinking about neighborhood safety and whatnot. They're related. So these are going to add up to more than 100. That's okay. But we found that about a third of the effect on moving is mediated by these changes in neighborhood stress. And we think this is really quite powerful, and I think kind of important in how we think about interventions for asthma. And there's lots of reasons to think that like focusing on the neighborhood, the stressful conditions in the neighborhood could matter and have like biologic plausibility, to have an idea that this could actually get into the body. One way is that stress can cause inflammation, and kind of that inflammation can reduce the response to treatments and also potentiate, kind of make the exposure to allergens worse. Stress can also be related to the way that we go about seeking healthcare and the way that we use the healthcare interventions that we have. Stress can also change the amount of time that you spend indoor, and change your level of exposures to different asthma allergens and triggers. They can also kind of change your amount of sedentary activity, leading to kind of leading to greater risks of obesity, and that can be an important risk factor for asthma exacerbations. Then there's also the potential that like feeling high levels of stress can change your perception of your symptoms. We think that that may matter for the kind of recall of the symptoms over the last 2 weeks, but it's less likely to be a major factor in thinking about rates of exacerbations of which require you to get a medicine from the doctor in order to treat it. So we think again that some of the key findings here are really about the changes in stress that happen. That yes, there's changes in allergen levels, but that we need to think more broadly about interventions.
These are some of our lung function findings, and I just want to underscore again what Craig said earlier. The reduction in exacerbations is huge from a healthcare standpoint, and we were really, really excited about this. This finding is also really clinically exciting. So FEV1, or the forced expiratory volume in 1 second, is how much air you push out in the first second when you're doing a forced exhalation. If any of you either has asthma or you have a child with asthma, you may have gone to your allergist or pulmonologist office and done this in the office, where you put a tube into your mouth and you breathe out hard and fast as you can, and it's hooked up to a computer, and it measures how much air you push out in this first second, how much air you push out in total. This FEV1 is clinically very relevant because we know as children grow, their FEV1 actually increases as your lungs are growing. And then around age 25-ish to 30, you actually start to lose lung function. So unfortunately, most of us on this call are all on the downward slope of lung function loss in life. And having asthma already puts you at risk for having lower lung function. Having repeated exacerbations is one of the biggest risk factors for having lower lung function. And we know that the current asthma treatments that we have, the mainstay being inhaled steroids, when you think about children or adults who use an asthma inhaler, they actually have no effect at all on lung function over time. Some of our newer biologics or the injection asthma medicines do affect lung function while you're on the medicine, but not so much once you stop those medications. And so our current asthma therapies are not thought to alter lung function at all for the long term. And lung function, not only for asthmatics, but just in general overall health, has been associated with increased risk of hospitalization, as well as overall increased risk of mortality. And so altering lung function actually can have a huge long-term effect on lung health and overall general health. So this finding is really exciting.
Based on
Sorry, go back, Craig. Let me explain the finding.
Sorry.
I realized I just talked about lung health. So you can see here at pre-move, the children, like we said, children's lung function is increasing because their lungs are growing. And then post-move, they actually had a greater increase in the rate of lung function growth. And so they were able to acquire greater lung function at rates that we don't see when we're like following children with asthma. And so having better lungs and lung health in childhood sets you up for better lung health in adulthood.
I was so excited to take the baton and talk about these findings. So based on this, we received funding to follow this cohort for longer. So there are about 122 families that were eligible to participate, and we currently enrolled about 71. Numbers increased a little bit since this slide was put together. So the study results we presented, we had about a year of follow-up after families moved. And as you might imagine, like when anyone has moved, like there's a lot of change that happens in that first year, right? Like changes to the conditions of the home, changes to your social environment, so many different things that are going on. And so we are going to be following up families for up to 5 years, doing the same protocol that Lakin had mentioned, where we're doing home visits every 6 months, telephone calls in between, to try to understand in greater detail kind of what's continuing to change with these children's asthma symptoms and their exacerbations, and what's kind of driving some of these changes. And so we are excited to come back in 5 years and hopefully before that and talk to you about what we found, and hopefully the results will continue to be exciting, right? Like they may go back and the effect of moving may just be a short blip in that 1 year, but I think based on what we've been seeing with the Moving to Opportunity study and some of the work with the families that we've had, I think that this is, much more exciting than that. I also want to talk for a moment about some of the other work that we've been doing in conjunction with the Baltimore Regional Housing Partnership. So in part based on the successful result of the Mobility Asthma Project, we've been working with the Baltimore Regional Housing Partnership to try to stand up a pilot program. And really excitingly, the Baltimore Regional Housing Partnership is on the same page and on the same team as the Housing Authority, and they are working to try to recruit kids with asthma and other conditions that might benefit from helping them move from areas of poverty into more opportunity neighborhoods. They've been working and trying to recruit from healthcare providers, trying to recruit from things like in Baltimore, there's a group that goes out to try to do home visits and redress asthma triggers in the home, trying to say, like, who are the families that could benefit and refer them to this program. I would say it's been tricky working with healthcare providers. As a primary care doctor, like, I understand this trickiness really quite well, that it can be hard for healthcare providers to have this top of mind, to be able to refer patients that might be interested in moving, to try to identify families that potentially have a voucher. And I think this is a place where we're doing a lot of work, but I think there's a lot of potential synergies around kind of thinking about how housing mobility programs, housing authorities can really partner with healthcare providers, and we'd be happy to talk about that. We've had some experience with working out the data sharing agreements, we've learned a lot along the process, and are excited to see how this plays out, and I think offers a lot of opportunities. The other direction that I want to share is that we also got funding from the NIH to do what we're calling the MOVE study, or the Mobility Opportunity Vouchers to Eliminate Disparities. And this is really an add-on project to HUD's Community Choice Demonstration, which many of you on the call may be familiar with, maybe some of you are participating in, where families are being randomized to receive comprehensive housing mobility services versus a control arm to help them overcome barriers to moving to opportunity neighborhoods. From the sample, we've partnered with 3 different sites: Nashville, Pittsburgh, and Cleveland, selected for geographic diversity and other reasons, to recruit a sample of about 900 families, 450 in the comprehensive mobility service, 450 in the control arm. And we were funded to study changes in obesity and diabetes risk, given kind of the extent of those problems across the United States. And again, similar to the asthma study, we're really interested in what are the factors that are along the causal pathway, what might be driving some of the changes. And so we are currently in the planning phase of that, developing the survey that we're going to be implementing, hopefully starting in January. And with that, I want to end with just these kind of conclusions and implications, which is this idea that interventions that seek to address the legacy of structural racism are really strongly positioned to result in health benefits. That the extent of the reduction in exacerbations are really, really strong. The findings that Tori mentioned around lung function growth, we think are incredibly exciting and preliminary at this point, but we're hoping that longer term follow-up is able to kind of demonstrate that there are changes that that potentially persist, and changing the trajectory there would be huge. And that, again, contrary to our a priori hypothesis, that it wasn't just changes in allergens, although those happened in our cohort, but really that these kind of broader experiences of living in these different neighborhoods were really important along the causal pathway in explaining. And so we think kind of that it raises questions around focusing on a piecemeal approach to addressing asthma and thinking about kind of how do we address asthma and other health conditions that children are facing in a more robust way. So all of us have been using this "we" term because this has taken a huge team to be involved in this research, including Elizabeth Matsui and Corinne Keed, who are the principal investigators of the study, along with myself. I have many other people listed who have been collaborators on this study. And of course, we're really grateful for the families who allowed us to come into their homes time and time again to try to understand what's been changing in their lives and what's the impact of these types of programs on their children and their families. So I think we have, plenty of time. That was our last slide. So we have lots of time for questions and discussion, and we'd love to hear what are the questions you have, what are the work you're doing, how this aligns with what you're doing in your housing authority to think about the connection between housing and these other factors.
Jennifer, I'll let you take it away.
Thanks, Camille. This was an excellent presentation. Thank you. Definitely want a copy. I represent, my name is Jennifer Thomas. I'm the assistant director here at the Housing Authority, City of LA, and we're doing a similar study with the University of California, Los Angeles. And we are doing the exact same study. We don't have the key indicator of housing mobility, and we're still cleaning our data, so we don't really know what the findings are, but we are looking at similar indicators. I guess my question is, for those who did move, are there any, like with the control group and for the ones that move? For the control group, were there any of your participants that opted not to move? And for those that potentially opted not to move, what would be some of the recommended suggestions to improve asthma-related conditions? Because I think that's where we're at. We're not moving anybody. We're just trying to understand kind of what the conditions are so we can address it. So I'd be really interested to know if you found any data related to that.
Yeah, so in this study, we didn't really look at the people that didn't move. We were really interested in what were the people that moved, recognizing that could add some bias to the study, but we thought that the vast majority of people who we recruited ended up moving. I think there's kind of like two things in your comment that I want to kind of bring out that I think sometimes come up. One is this, like, for the people that are not moving, like, what do we do for them, which is what you asked. And then for the people that are moving, like, there's some concern that, like, that then that unit is going to be empty and maybe it's going to go to another voucher family, and like, are they going to be exposed to these allergens, these triggers in their environment? And so, like, what do you do, right? Like, you don't want to just you just want to kick the can along. Well, it's not my problem, it's this other family's problem, right? Like, that seems very unsatisfying. And so now that I framed the question and made it even harder, I'm going to ask Tori if she has any thoughts. Tori's a pediatric allergist by training.
Thank you, Craig. So this is, like I said before, the results of us going into homes in Baltimore have been unfortunately inconsistent and mostly disappointing. And so we use this study to really point toward that a more neighborhood level change is needed versus an individual or patient level change, often for these kids who are living in in environments with really high allergen exposure. I'm originally from Southern California, yay, LA. And so the allergen exposures in LA are a little bit different than a lot of the major urban centers in East Coast cities, such as Baltimore or New York or Philadelphia and DC. Not as much mouse and cockroach exposure, still there, but not as prevalent. And then the other allergens, such as the cat, dog, dust mite, and mold, which we didn't look at specifically in this study, but mold allergen exposure is also a known contributor to both risk of asthma and asthma morbidity. LA is a very damp city, so there is lots of mold exposure there. And so we don't, like Craig said, we don't want to leave other families behind, but we really see this as a call to a need for a broader community level change. And from the individual level, we do know that getting connected with an asthma care specialist does help improve asthma outcomes and does improve access to asthma medications compared to children who don't see an asthma specialist. And we do always try to recommend allergen mitigation and remediation for mold, but sometimes that's very costly and difficult for the families to attain themselves, if that makes sense.
And I would also add that I think that, that a lot of the things that are going on that I'm familiar with in LA, in part through kind of researchers at UCLA and USC, is kind of some of the, redevelopment that's happening, whether that's transit-oriented redevelopment or Hope 6. And, I think the impact of those on asthma, I could imagine could also be quite strong, especially if you think about some of the broader mechanisms. Some of it is around these kind of like mold and these kind of like what we think of as the traditional asthma triggers, but also thinking about kind of some of the neighborhood safety and the other factors that we're looking at.
I'm also thinking, based on these results, things like choice neighborhoods, where we're really trying to change the neighborhood conditions, are going to be some of the good tools available to us. But also, Jennifer, I know you all have a really interesting stress management program. And based on these results, considering how important stress has been, maybe that's something to kind of lean into and make sure families that have children with asthma are really able to access those resources and the stress management coaches.
Yeah, I mean, we definitely have the USC study. It's more longitudinal. We're looking at kind of the social determinants of health and the built environment, right? And that's connected to our George Downs CNI grant. So we will be comparing that. And then, of course, really looking at trauma-informed services, right? Because we have a lot of community violence just across the board. So really, yeah, helping with that. And then we infuse that with the mental health counseling. So we're really trying to look at all these factors. But no, this is really interesting. Something I definitely want to track. Thank you for sharing.
Phoebe, your hand was next.
Thank you. Hi, everybody. Excuse me. Thank you for the presentation. That was great. Also, Jennifer, that stress management program, maybe I'll follow up with you. That sounds interesting too.
Phoebe, you're a little hard to hear. Maybe lean in.
I think
There
is
we
that
go.
better? My microphone was up, sorry. I said thank you for the presentation and also the stress management program that you just mentioned, Camille, Jennifer. I'd love to hear more about that. But I guess it's kind of a question for you. I'm thinking about, I'm at King County Housing Authority. We're not doing research around this specifically, but I am thinking about I guess neighborhood, the effects of the neighborhood, and wondering if there's maybe some parallel when I think about public housing kind of properties or projects that are just not a neighborhood necessarily, but a large complex with lots of folks, and thinking about whether there's opportunity for addressing the environment there if we can't move people. If like moving folks with vouchers to different neighborhoods might be too big of an undertaking, or it would be for us. But I'm just thinking about, have there been any studies, or have you thought about those implications about, I guess, like the stress reduction part of it on a neighborhood wide level, but just kind of smaller when it's the environment that folks are living in, where we do have an opportunity to change lots of things, I guess, or provide lots of different types of interventions that could address stress levels or cohesion or some of those things you mentioned on a property level.
This is a great point, a really great question, and it's interesting because I feel like Seattle King County, with creating Moves to Opportunity, has been the leaders in some of the mobility studies and approaches. And I think for the kind of what can be done in public housing or large kind of family-oriented housing and the like. I think it's such a great question and idea, and I would be curious for people on the phone, kind of what are the approaches that work to promote safety, right? Like the idea of being able to walk safely at day and at night is, it's such a simple seeming question, but I think there's so much baked into it around people that are feeling stress, and it's less of a kind of an individual rates of depression, right, or that kind of wellness approach, which I think is also important, but was less of a mediating factor in the study, and I think speaks to kind of these broader neighborhood conditions, and whether that is through like the choice neighborhoods, which I recognize involves like a large infrastructure project, but wonder what else has been successful in kind of promoting safety and security, and wondering whether in some of those projects you can measure what I would call spillover effects on asthma. So I'd be very curious what would work for that.
Katie, you're up next.
Yeah, that's kind of exactly in line with what I was thinking during the presentation. I think it just really emphasizes the importance of place-based initiatives and investment in historically underinvested communities and neighborhoods. So, the majority of our folks are going to be living there. And so at Tacoma, we've done a lot of intentional community building in the Hilltop, and also Salishan, which is a neighborhood which has actually had a lot of violence this last year. So we've really emphasized, I think, a lot of community building, community strengthening activities. We have community advocates that are trying to activate the communities and to build that social cohesion. Our service model is really focused on social emotional learning. And so I think really some of that stress reductions, I'd love to hear more about that from LA and from CLAPA. But yeah, I think like as an industry, just like these findings also really just underpin, we've been focused on mobility, but just I think like underpins the importance of also doubling down on our efforts around community building and community development work as well, because those impacts are huge, and that kind of really stuck out to me during the presentation. So I just really appreciate, just how important those stress factors are, and like we know that, but just like having the data to emphasize that in our communities and with our local policymakers.
Yeah, I just want to say I really appreciate that perspective, and I think that often, like in the kind of policy world, it's either like you're working on mobility or you're working on place-based solutions, and it's like a zero-sum game where you're doing one or the other. And I think that's right. Like we want these results to reflect on what can work, for mobility options, and that is a policy tool for some families, but also recognizing that like not everyone wants to move, and not every, and so what do you do? How the results kind of be applied? And I think, we would love if folks are doing work that's kind of looking at these kind of place-based strategies and interventions that are really seeking to increase neighborhood safety, or really kind of fundamentally change neighborhood environments. I know Jennifer brought up the USC study that's been going on with some of the, we think those are incredibly important, and that's maybe on the extreme, but there's a lot of other things that housing authorities I think are doing, and we'd love to learn more about what's happening and how we can kind of capture its full impact.
Jennifer, go ahead.
Well, coming from a non-MTW housing authority,
I feel like there's some divide going on here. We're not getting involved in that.
We're very creative in how we implement things. So, just internally, what we did, we really focused on our resident advisory committees. We didn't have a budget. We partnered with Coro. It's a nationwide public affairs fellowship program, and they have graduate interns that take on a project for a year, and we approach them and ask them to do some leadership training with our local RACs. That was in kind. They funded it. We partnered, developed a non-financial MOU that came in, and they still do. They train our RACs and Robert's Rules of Order, leadership skills, and that kind of thing. They even taught them how to plan events, right? How to do outreach, how to advocate for their community with their local city politicians, like city council and that kind of thing, how to understand the government process. I mean, these are all intangible skills when you're organizing. And then we just reached out to local organizations to partner to do community resource events. And we did those in partnership with our RACs. So the RACs were the lead. My staff were really the backbone in putting the event together, but we let the RAC be the face of the event so they can learn how to really partner. We got our Head Starts involved. We got our schools involved, our community organizations, our mental health providers, and just had, quarterly events. And then eventually we raised some capital. I think I only budget like $10,000 for about 14 public housing sites. And we have our managers kind of take the lead on the request. So it's kind of like a first come, first serve. But the whole idea is to put our managers kind of at the sites in partnership with the RACs to do resource events at their sites. It takes our managers away from just lease enforcement, right? And puts them in a positive light to the community. It also creates a space for the seniors to come out and for us as staff to really hear what their needs are. So it's really organized, but it's on the ground. It's really viewed as an organic kind of community building activity that is very minimal on our budget, heavily resourced with partners, and it helps us really understand the needs of our residents in a more organic way. So that's really how we started. And then I posted the community safety partnership link that was done. It was an analysis done by UCLA to really look at our community policing strategy. Rave reviews from our residents. Our police officers partner with the local police athletic league, and they actually raise funding as well to do events, to do field trips with youth. They offer the Police Cadet Academy for the juniors, the junior cadet program for youth starting in middle school to teach them leadership development. Some of them go to the academy, some don't, but at least they have a better understanding of how law enforcement works. And then they report back to our RACs and our seniors on the types of activities that they're doing. And that has fostered way better relations with our police officers and has really built the trust. And we incorporate them into all of our events, our meetings, et cetera, so that the faces are seen over and over with our residents. And they have now become a trusted source. So take a look. We've gotten some nationwide reviews on that. We've taken it on the road. We talked to Chicago. We've presented in Sandtown, actually, in Baltimore, on our strategy. So we're really proud of some of the strides that we've made in the last decade or so with limited budget.
I'm impressed with what you've gotten done with the limited budget, particularly in such a large city. Well, we are just about at time. I will note that I heard the request to hear more about HACLA's stress management program, and Jennifer, you aren't off the hook because I also want to make sure we highlight that soon. So we'll bring that around with Housing Is, and I'll work with Jennifer to highlight that at a future event. I just want to say thank you so much to our Hopkins team. Really interesting research, really insightful, and really reinforces the importance of mental health on physical health. I think it's just another point of how important mental health is what a big impact we can have on the kids that we serve as well. Any last thoughts, Hopkins team?
We just want to say thank you. We really appreciate the chance to talk with you all and learn from you about the work you're doing. So we really appreciate it.
Great. Craig put his email in the chat. I will have this recording also posted on Housing Is for anyone who wants to review it again. Thank you again. Really appreciate you all, and hopefully we'll see you all next month.